This lecture from the musculoskeletal system will focus on fractures. You will need to know several different types of fracture terminology. The image you see on the PowerPoint depicts for you several different types of fractures that can occur. We're going to look at each one of them and discuss the definition. The first type of fracture that you see here is known as the transverse fracture. A transverse fracture is one that occurs simply straight across, perpendicular to the pathway of the bone. The next one we see is the linear fracture. A linear fracture is one that occurs parallel or lengthwise within the bone. The oblique fracture is one that occurs across and down. In this example, we see also a non-displaced and a displaced fracture, two additional terms that you need to be familiar with. You'll notice with the first oblique fracture, this is a non-displaced fracture, and what that means is that the bone remains in alignment. With the displaced type of fracture, you can see that the two broken ends of the bone are separated. In this case, those broken ends of the bone would have to be realigned in order for proper fracture healing to occur. The next type we see in the image is known as the spiral fracture. A spiral fracture occurs when at least one part of the bone has been twisted as it was broken. It can appear somewhat similar in a blank image to the oblique fracture, but you'll notice there's two red arrows there depicting that the bone was actually twisted as it was broken. The next image refers to the green stick fracture. The green stick fracture is a fracture that is known as an incomplete break. This type of fracture occurs in children. It usually occurs in children because their bones are more flexible and slightly softer than that of an adult. With the incomplete fracture, with the green stick fracture, which is an incomplete break, the bone is usually broken on one side and bent. The last image that you have here on this screen is the comminuted fracture. The comminuted fracture is one that results in several fragments. As you can see there, between the broken ends of the bones are several small pieces. These pieces have to be either cleaned up or they have to be replaced. If they can be replaced, usually with pins and screws and plates, if they're necessary to be kept to maintain the integrity of the bone. If not, oftentimes if there's very small broken pieces of bone, those may just be removed. There's a couple of other terms that I want to go over with you that aren't on this slide. Another one is a couple more terms, and I use this term in relationship to the green stick fracture. I use the term an incomplete fracture. So those are two additional terms to be familiar with, is the complete and the incomplete fracture. So with the complete fracture, the bone fragments are separated completely. With the incomplete fracture, the bone fragments are still partially joined. Again, referring back to your example there of the green stick fracture, that is a type of incomplete fracture. Another few terms that we don't see on here is the stress fracture. Stress fractures are ones that can occur from either repeated or prolonged stress. Oftentimes these can be incomplete fractures as well, and they can be along different pathways of the bone. The pathologic fracture is another one that we need to be familiar with. A pathologic fracture is one that occurs related to something such as a tumor or a disease process that has caused a spontaneous break. Some common conditions that can cause pathologic fractures are bone cancers, as we'll talk about in a different lecture, and osteoporosis, which we will also discuss in a separate lecture. Two final terms that I want you to also make a note of are what we call an open fracture and a closed fracture. And obviously these two types of fractures can occur with any of the types that we've discussed here, especially any type of displaced fracture. The open fracture can occur with the displaced fracture when the bone is piercing through the skin. With the closed fracture, the bone does not break the skin. So again, we could possibly see, as an example, you could see an open oblique displaced fracture, just like you could see a closed oblique displaced fracture. So we've got three different terms there referring to one type of fracture. I also want to take a moment to mention in your pediatric textbook, you can review information regarding fractures, concerns that we have specific to pediatric patients. And these are fractures that occur along the growth plate. The growth plate is also known as the epiphyseal plate. This is a plate that allows for long bones to grow to an adequate length prior to puberty. As a child passes through puberty, those growth plates close off, sealing those long bones at the length that they will remain for the rest of that individual's life. If a fracture occurs in a child along a growth plate, this type of fracture is particularly concerning because if it is not realigned perfectly, if it's not immobilized properly, that child can impair the healing of that bone, and it can lead to problems with the child's growth and development down the road. Therefore, it's always recommended if a child suffers any type of fracture of a long bone, such as the humerus or the femur, that child has to be evaluated by a pediatric orthopedic surgeon to ensure proper immobilization and proper realignment of that fracture, taking that growth plate into consideration so that there is no long-term growth deficits with that child. Fracture healing is a process that begins as soon as the injury occurs. Healing occurs in 5 stages. The first stage of fracture healing is known as hematoma formation. This is when bleeding begins immediately after the fracture and forms a clot around the broken ends of the bone. Stage 2, known as the granulation formation stage, happens when granulation tissue replaces that clot, and the granulation tissue then forms a collar around each end of the broken bone. This forms a bridge between the 2 broken ends and creates an unstable support. Stage 3, known as callus formation, occurs when the granulation tissue changes into a callus. This helps to serve as a temporary splint. It's strong enough to keep the bone fragments together as long as it isn't stressed too much. During these first 3 stages, it's very important that proper immobilization takes place. Stage 4, ossification, is when the permanent bone callus begins to form. What started off as a soft callus becomes a hard callus. The broken ends of the bone begin to knit back together, resulting in what we refer to as woven bone. Woven bone is 80% as strong as normal bone. Once woven bone has set in and begun to form in the bone, this is the earliest stage in which immobilization devices such as a cast could possibly be removed. Stage 5, known as consolidation and remodeling, is a process that takes many months and even up to a year or more to occur. During consolidation and remodeling, the distance between the bone fragments decrease and then close. The immature bone cells are gradually replaced by mature bone cells, and the bone resumes its original shape and size. During stage 5, the bone recovers almost all of its pre-injury strength. We have to consider, although these are the 5 stages that we expect fracture healing to occur in, there are several factors that can play a role in this process and potentially prolong it. One of the first factors that can affect fracture healing is the location and the severity of the fracture itself. For example, a displaced fracture is going to take longer to heal than a non-displaced fracture because it's likely going to require additional interventions that the non-displaced fracture did not require. Another factor is the type of bone that was broken. The long bones of the body or the weight-bearing bones of the body are likely going to take longer to heal than a bone that is a smaller, non-weight-bearing structure. Blood supply to the area is also important in the healing process. If the blood supply to that area was damaged as a result of the break, this can impair the healing process. If an infection occurs in addition to the fracture, that's going to prolong the fracture's ability to heal. Open fractures and fractures requiring surgical repair are going to be at higher risk than other types for developing infection. The adequacy of the immobilization is another important factor in fracture healing. As I mentioned within those earlier stages, the healing process that we see occurring in the hematoma formation stage or the granulation formation stage are very unstable structures. So immobilization is critical in making sure that that bone maintains alignment during those stages. If immobilization is not done correctly, it can cause the fracture to heal improperly, or it can delay the healing time altogether. Some endocrine disorders can also play a role in the fracture healing process, but one of the most important factors that we need to mention is age. If none of these other conditions are present, age alone can be one of the most prominent factors that can play a role in fracture healing. It can take 6 times longer for the same type of fracture to heal in an older adult versus a small child. As an example, if you were to take an 8-year-old and an 80-year-old and they were both to suffer the exact same fracture of the radius, where the 8-year-old may be casted for approximately 4 weeks, the 80-year-old may take a minimum of 8 to 12 weeks of wearing a cast before proper healing has taken place. When assessing for fractures, we're going to focus on 3 main criteria: color, sensation, and motion. When we think about color, or the C, we're going to be thinking about circulation. We're going to check that the skin on the affected extremity is pink or their color ethnicity. We're going to want to check capillary refill and the pulses distal to the injury. For sensation, we would ask which finger or toe am I touching, and motion, we would ask if they can move their fingers or toes. Sensation and motion, we're really focusing on their neurological status, making sure that no nerves were injured in relation to the injury itself. And the same thing with the color and the circulation, we're making sure the blood supply was not affected as a result of the injury. When it comes to fracture repair, we have several different approaches that can be taken. We have different types of immobilization. We have what's known as reduction, fixation, and traction are all applications that can be used to repair a fracture. Looking at immobilization first, this is absolutely necessary for healing of the fracture to occur. This is going to prevent movement and increase union of the broken ends of the bone. This is accomplished through things such as fixation, which we will touch on here in a moment, casts and splints, and traction, which we will also talk about separately. When it comes to casts, you have some images there of several different types of casts that could be used to immobilize a broken bone. They can be short or long. We can use casts such as a body cast, a spica cast, and even what we refer to as walking casts. We also have different types of materials that can be used, such as plaster or fiberglass. Timing of application of a cast is important. If a cast is applied too soon after the fracture, it can result in constriction of the affected extremity as swelling takes place. It's important to always check the fit of a cast because it cannot be too tight, and we'll talk about that here in a little bit. You should always be able to fit at least 1 finger inside a cast. We want to teach the patient that they should not insert foreign objects into the cast and that the cast should remain dry. So we have to provide them on instructions on how they can shower or perform daily hygiene and yet maintain the dryness and the cleanliness of the cast. Some differences between the types of material used to make casts are fiberglass casts are lighter and they are water resistant, and they usually dry in about 30 minutes after application. Plaster casts need about 48 to 72 hours to dry. They are a heavier cast and they are not water resistant. It's important that you do not handle a plaster cast with your fingers until it has had time to dry, because if you do, it can cause denting. And if there's indentations on the outside of the plaster cast, it will cause indentations on the inside of the cast, which can create pressure points on the patient's affected extremity. One advantage to plaster casts is that they are more moldable. So if they're needing to maneuver around a joint or a certain area, sometimes they may opt for the plaster cast because they can mold it to different areas of the body more easily than they can the fiberglass cast. Otherwise, for the most part, the fiberglass cast is the preferred method of casting nowadays. When it comes to the reduction of a fracture, this can be done two ways. We can do a closed reduction method or an open reduction method. With the closed reduction method, the physician is going to use a non-surgical realignment to return the bone to its previous anatomic position. They do not make a surgical incision. However, they may give some general or local anesthesia, and they will use traction or manual pressure or a combination of the two to manually realign the broken ends of the bone. After they use a method of closed reduction, they would want to take x-rays of the fracture and make sure that they got the bone in proper realignment before applying the cast. Another term for closed reduction is manipulation. One of the most common examples of a closed reduction that you might be able to associate with is if you've ever seen somebody with a broken nose, whether in real life or in a movie, the physician would take the nose and place their hands on either side of the nose and basically pop it back into place. They're realigning the broken nose. That would be an example of a closed reduction. An open reduction, on the other hand, is going to be when a surgeon is going to perform a procedure in which an incision is made at the fracture site. The area around the fracture is cleaned up of any fragments or debris. The fracture is stabilized, and it may or may not require any casting after the open reduction is complete. In conjunction with performing an open reduction, they would go ahead and do oftentimes fixation, which is the next item on our list to look at. Fixation is done when there is an attempt to attach the fragments of the broken bone back together. This is done using items such as pins, nails, screws, or possibly plates. The X-ray image you see on your screen shows an arm that has been fractured that has both open reduction done along with some internal fixation placed. Fixation can be internal or external. With internal fixation, the devices are placed inside the broken bone, and then the incision is closed back up after the surgery is complete, and you cannot see the fixation devices that were attached to the bone. With external fixation, the devices are secured into the bone, but they are brought through the skin and they actually are sticking out. So with external fixation, you can see the devices that were used to maintain the alignment of the bone. External fixation has to be used in conjunction with skeletal traction. We're going to talk about the different types of traction here on the next slide. When it comes to traction, we have a couple of different methods for doing this. Traction is a method for straightening broken bones and relieving pressure slowly over a period of time. We can do both skin traction and we can do skeletal traction. The first type, skin traction, works by applying a weight to tape, a sponge, or a canvas type of material that has been attached to the skin surrounding the damaged body structure. Skin traction does not require a break in the skin. It's generally used for short-term treatment, about 48 to 72 hours, until either skeletal traction can be placed or until surgery can be performed. One type of skin traction is known as Buck's traction, and this is a common type used for hip and knee contractures or hip fractures. Buck's traction helps to maintain alignment of a hip fracture prior to surgery, and it reduces muscle spasms and reduces the pain associated with the fracture. With skin traction, the weights are usually limited to about 5 to 10 pounds. Our other type of traction, known as skeletal traction, involves the placement of a pin, wire, or screw into the fractured bone. So as I mentioned on the previous slide, skeletal traction is done in conjunction with external fixation. Skeletal traction is generally in place for longer periods of time than skin traction. It provides a long-term pull that keeps the injured bones and joints aligned. Once the surgeon places the pins or wires into the bone, then weights are attached to those devices to maintain the alignment of the broken part. The weight that's applied for skeletal traction can range anywhere from 5 to 45 pounds. It's important that the surgeon gets the amount of weight correct, because too much weight can result in either a delayed union or a non-union of the broken bone. One of the biggest concerns and most major complications of skeletal traction is the risk for infection at the pin insertion site. Because of this, pin care has to be done every shift. It has to be done in a meticulous fashion using sterile technique and agents such as chlorhexidine. Nursing interventions for the patient on traction consist of 1, monitoring the weights, making sure that they're hanging freely at all times. The weight will be an ordered amount from the physician, and the nursing staff should never release the weight that is applied during traction. You should also make sure to maintain your patient's body alignment. Use padding to prevent injury. You're going to watch carefully for skin breakdown and assist the patient with their activities of daily living. It might not be possible for them to turn from side to side, but they will usually be able to lift and reposition to change pressure areas while they're in traction. You want to make sure you assess the extremity of the affected extremity with traction for color, sensation, and motion. You're going to check capillary refill, pulses. You want to ask about any pain and check for the presence of edema. You want to make sure if your patient's in skeletal traction that you are assessing the pin site on a regular basis, looking for any evidence of warmth, redness, abnormal drainage, or odor. Some clear serous or serosanguinous drainage. A slight amount is sometimes normal around the pin site, but obviously purulent or greenish, yellowish discharge or drainage is not normal, and odor around the pin site is not normal, and that should be reported to the physician immediately. In regards to assistive devices for patients with lower extremity injuries, we can use devices such as crutches, walkers, and canes. These are going to increase the patient's mobility, and it will assist them with ambulation. Patients must be measured for a proper fit. This is usually done by the physical therapist, and physical therapy oftentimes are going to be the ones to instruct the client on the crutch walking technique that they may be prescribed. However, nursing is going to be responsible for reinforcing that teaching. You also want to make sure that we discourage the client from leaning on the axillary bar. We want to note that they make sure that they have good upper body strength, which is necessary to be able to use crutches. If they are going to use a cane, it's going to be placed on the unaffected side. An easy way to remember cane placement is the acronym COAL, C-O-A-L, cane, opposite, affected leg. I want to note that there are different types of crutch walking techniques. I do not go over them with you, but they are covered in the ATI Skills Module Review, Ambulation, Transferring, and Range of Motion. in the video clip Ambulating with Crutches. I do want you to review that video, and I want you to be familiar with the different types of crutch walking techniques as they relate to the different types of weight-bearing status that may be ordered by the physician. We have some different types of fracture complications that we need to cover. The first one is osteomyelitis. Osteomyelitis occurs when there is an infection from contamination of an open wound or the indwelling hardware that was used to repair the broken bone. This can interfere with the normal healing process, and it is most common after an open fracture or a fracture that required some type of surgical repair. Signs and symptoms that we would see present with osteomyelitis could be local pain, redness, a purulent malodorous wound drainage. The patient will likely have chills and a fever, and one of the most significant symptoms would be if they did have a cast or a dressing in place, that there would be a hot spot over that cast or dressing. External traction is also going to be another risk factor for osteomyelitis. As you'll recall, with external traction, pins or screws were placed into the bone and were brought out through the skin. This has created a direct route into the bone if the pin site is not cared for meticulously. If osteomyelitis occurs in a fracture, it requires IV antibiotics for a prolonged period of time, generally at least 4 to 8 weeks, and can even be followed by 4 to 8 weeks of oral antibiotic therapy as well. The patient's going to require wound care, which may involve irrigation, treatment with antibiotic beads, even possibly surgical removal of dead bone tissue and/or removal of the hardware. And in the most severe cases of osteomyelitis, when treatment is not effective, the patient faces the possibility of an amputation. Our next potential complication is known as compartment syndrome. Compartment syndrome can occur as a result of internal or external pressure on the affected area. Internal pressure can come from bleeding or edema. When there's bleeding or edema into the area, then there is nowhere for the drainage to go. It can become trapped in the space. The increased fluid puts pressure on the tissues, nerves, and blood vessels so that the blood flow becomes decreased, eventually resulting in pain and tissue damage. External pressure can come from a cast or a dressing that's been applied too tightly. External pressure can be just as dangerous because it can decrease the blood flow to the area. If this is not identified and treated promptly, it can progress to sensory loss and paralysis. The most notable symptom of compartment syndrome is worsening pain, especially with touch or movement and pain that is not relieved with opioid medications. Some other symptoms that we would see to support compartment syndrome would be the presence of edema, pallor or cyanosis in the affected extremity, weak and unequal pulses, and paresthesia. We have what's known as the 6 P's of compartment syndrome, and this is one way to kind of think about the signs and symptoms associated with it. The first P is pain, so we would palpate the entire extremity and note the increase in pain even after being medicated. We would look for pallor, that's your second P, so that's going to remind us to note the color, temperature, and capillary refill of the extremity. The third P stands for pulses, palpating them both proximally to the injury and distally. The fourth P is paresthesia, so you want to assess the patient for burning, tingling, and numbness in the affected extremity. 5 is paralysis. This reminds you to assess motor function, both active and passive, of the affected extremity. And the last P is for pressure, palpating for any firmness of the compartment or the area that is being affected. Our goal with compartment syndrome is going to be that we relieve the pressure in the affected area. And this is going to be done one of 2 ways depending on what's causing the pressure. When the pressure is internal, the best option is known as the surgical fasciotomy. This is when the surgeon is just going to create an incision into the skin to allow the bleeding or edema that is developing to escape. If the pressure is being created by an external source, such as a cast or a dressing, then that cast or dressing should be removed with physician's orders and replaced. Other treatments for compartment syndrome would consist of avoiding elevation of the extremity. We would actually want to lower the extremity to improve blood flow to the area. We would also want to avoid ice, as this would cause vasoconstriction and decrease the blood flow to the area. Another type of complication we can see in relation to fractures is an embolism. We actually have two types of embolisms that we want to talk about. The first is the VTE, the venous thromboembolism. This is going to occur after fracture or immobilization, such as those of the lower extremities. The longer a patient is immobile, the higher risk they are for the development of a VTE and then the subsequent complications that come with a VTE. As stated there, these can break off and travel to the lungs, causing a pulmonary embolism. The fat embolism, on the other hand, is going to be something that the patient is most at risk for within 24 to 48 hours following their injury. It's also going to be more common in fractures of the long bones, patients with multiple fractures, and patients with severe trauma. A hip fracture is one that carries the highest risk for the development of a fat embolism. What happens with the fat embolism is that fat cells are released from the bone marrow and they're able to get into the bloodstream and migrate to the lungs. Ultimately, a fat embolism would cause the same physiological outcome as a VTE. They just occur at two different time points following the fracture. Both of them would ultimately result in a pulmonary embolism. Therefore, in the fracture patient, it's important that we have an ongoing assessment of their respiratory status from the time the fracture occurs and throughout their immobilization period. Just remembering that the potential for the fat embolism is going to be highest in the first few days following the injury, whereas the potential for the VTE is going to be highest the longer the patient remains immobile and on bed rest. Some other types of fracture complications that can occur are joint contractures and stiffness. These are going to be common in relation to patients who have wore a cast for a prolonged period of time that has covered at least one joint or more in their extremities. Malunion, non-union, and delayed union all refer to terms in which the broken bone does not properly realign and reunite. Malunion is when it heals improperly. Non-union is when it does not heal at all, and delayed union is when the bone eventually heals, but it takes longer than what we expected it to take. Another potential problem is known as avascular necrosis. Avascular necrosis occurs when, usually when the blood supply to the area has been interrupted to the point that the bone doesn't have adequate blood supply in order to heal. And in this case, because of the lack of blood supply, the bone tissue actually begins to die off. As we wrap up, we're going to look at a couple of different types of specific fractures. The first type is the facial fracture. It's important to note that this can cause problems with vision. It can cause problems with their brain, swallowing, breathing. So it is necessary to have suction ready and to maintain C-spine stabilization for somebody that has suffered a facial fracture until we're sure the extent of their injuries. In regards to mandibular fractures or broken jaws, first of all, some signs that we can see that is indicative of this is that they have possibly some broken teeth, that they're not able to open or close their mouth all the way. Mandibular fractures oftentimes do require jaw wiring. So if jaw wiring is done, they are going to be at an increased risk of aspiration. It's really important that we make sure to prevent vomiting and that we teach the patient that they have to carry a pair of wire cutters with them at all times. They're going to have to maintain adequate nutrition, so they're going to need some education on altering the consistency of their food and how they can still maintain adequate nutrition with their jaws wired shut. Looking at pelvic fractures and hip fractures, pelvic fractures do carry a high risk for mortality, high risk for internal bleeding, fat embolisms, and even then down the road as they go through the recovery phase, they're at risk for the development of VTEs as well. We watch very carefully for abdominal rigidity or swelling. This can indicate to us internal bleeding in relation to a pelvic fracture, because it is possible with our pelvic fracture patients. Oftentimes pelvic fractures tend to be comminuted fractures, so there can be multiple broken pieces that can damage the internal organs. This is also why we check for urine and blood in the urine or stool. The treatment of the pelvic fracture does depend on the severity of the fracture. Some patients can be treated with just a little bit of bed rest and a firm mattress for just a few days or a few weeks. Some patients require pelvic slings. Some require skeletal traction, surgery, maybe a spica cast, or even external fixation. It really depends on the severity of the fracture itself. The hip fracture. This is a fracture that has increased in incidence in our elderly. Signs and symptoms classic to the hip fracture are going to be that there is external rotation of the affected extremity, and the limb on the affected side is shortened compared to the opposite leg. The medical treatment recommended for the hip fracture is possibly traction followed by surgical repair. We don't see traction used as often as we used to preoperatively. We used to see Buck's traction used quite a bit in the preoperative time period for the hip fracture patient, and now we don't tend to see that used as much. However, surgical repair is the recommended treatment for any type of hip fracture, and it should be done. What should be done is either an ORIF, which stands for an open reduction internal fixation, or an arthroplasty. An arthroplasty is replacement of the hip joint. Hip fractures are frequently related to osteoporosis in older adults. Therefore, the decision between an open reduction internal fixation and an arthroplasty usually comes down to how severe of osteoporosis the patient has. The less dense the bone, the less likely it's going to be able to handle the placement of pins with the open reduction internal fixation. So in patients with low bone density or osteoporosis, they're going to more often be a candidate for a hip arthroplasty and replacement of that joint versus the open reduction internal fixation. An ORIF requires a more dense or thicker bone material in order to be able to stabilize the fracture. The ORIF or the arthroplasty, either one, is important to get done on the patient as soon as it is medically safe for it to be done, because this is how we're going to be able to get the patient up and moving around. The physician will order weight-bearing orders for the ORIF or the arthroplasty patient as soon as they come out of surgery, and oftentimes we will be getting these patients up and out of bed within about 12 to 18 hours following their surgery. We're going to have them having some level of weight bearing on that affected extremity. If the patient had the arthroplasty done, they're going to be required to follow the same instructions as any patient with a hip arthroplasty would. We'll go over the hip arthroplasty post-op considerations in a different lecture.